This is Pam Williamson, and I am from the Southeast ADA Center. And although I am based in the southeastern states, I have strong ties to Missouri in that my son graduated from Missouri State in Springfield, Missouri, and he and his family currently live there. So now take us to the next slide, please. And one more. And you'll be introduced to Troy Balthazar momentarily, and he can tell you a little bit more about himself. So next slide, please. I do have to give a disclaimer. We are funded through the National Institute on Disability, Independent Living, and Rehabilitation Research, and that's a center within the Administration for Community Living, Department of Health and Human Services. And this presentation does not necessarily represent the policy of NIDLR, ACL, or HHS, and you should not assume endorsement by the federal government. We do provide informal guidance on the Americans with Disabilities Act, and we are not an enforcement agency, and our calls center is open to anyone who needs to know more about the Americans with Disabilities Act. Next slide, please. So what is the ADA National Network? So we're 10 centers, and we provide, again, information, guidance, and training on the Americans with Disabilities Act. And Troy and I are representing two of those 10 centers today. If you remember nothing else from our presentation, I encourage you to make sure you have our toll-free number, 1-800-949-4232, and our website, adata.org. So we are all about making it possible for everyone with a disability to live a life of freedom and equality. Next slide, please. As we've already mentioned, we're funded under the U.S. Department of Health and Human Services, Administration for Community Living, and NIDLR. Next slide, please. So we're going to talk a little bit about civil rights and telehealth, and what does that mean? So as we move forward, so we're going to look at 3 federal civil rights laws that address telehealth and disability issues. The first is the Americans with Disabilities Act, which was passed in 1990. The Rehabilitation Act of 1973, specifically Section 504, and then the Patient Protection and Affordable Care Act, specifically Section 1557. Next slide, please. Overall, our federal civil rights laws provide a general rule that no qualified individual with a disability shall, on the basis of disability, be excluded from participation in or be denied the benefits of the services, programs, or activities of a covered entity, or otherwise be subjected to discrimination by a covered entity. So just to give you an example of what that might mean, a healthcare provider who offers telehealth services may violate the law when they adopt a blanket policy of refusing to schedule telehealth appointments for any patients with intellectual disabilities, because they wrongly assume that these patients may have a difficult time understanding how to navigate the online platform used for telehealth appointments. The provider must offer these patients an opportunity to participate in telehealth appointments equally to that given to others. Next slide, please. Now, the Americans with Disabilities Act, as we noted, was passed in 1990, and it promotes equal opportunity for people with disabilities in employment, state and local government agencies, and private businesses. The goal of the ADA is the full inclusion of people with disabilities in all aspects of American society. It has 5 sections. The first one deals with employment, the second, state and local government programs, and that includes health care. Public accommodations, or also known as private businesses, and includes nonprofit groups, also including healthcare, transportation, which falls under Titles 2 and 3, and then telecommunications, which falls under Title 4. Next slide, please. Section 504 of the Rehab Act applies to any healthcare provider that receives federal funding. and individuals with disabilities must have an equal opportunity to participate in and receive all the benefits of the services, programs, and activities offered by any entity covered by these laws. So if a healthcare entity receives Medicare funding or other federal funding, then they would be subject to the requirements of Section 504 of the Rehab Act. Next slide, thank you. So the Affordable Care Act, specifically Section 1577, provides that covered healthcare programs or activities provided by the covered entities through electronic or information technology must be accessible to individuals with disabilities, unless doing so would result in undue financial and administrative burdens or fundamental alteration of the health program. Now, at this point, I'm going to turn it over to Troy, and he's going to talk about some more examples of what this might look like.
Thank you, Pam. And I think Pam did a good job of sort of telling you who we are. We're at the Great Plains ADA Center here. I'm the director. So we're here if you ever need anything related to the ADA. We're here to support you in meeting your needs in that regard. So please don't hesitate to ask us. Yes, just get into the telehealth specifically and disability considerations there. As Pam noted, this is based on the ADA, the Americans with Disabilities Act. And so here are a couple of considerations. For effective communication means that communicating with people who have disabilities affecting any areas such as vision, hearing, or speech is as effective as communicating with people who do not have these related conditions in the same situations. So the key terms to bring out of that are as effective. So doesn't need to necessarily be better. It needs to be as effective as what we provide to everybody else in the same kind of situation. So again, applying it to that current standard and how things are generally done. So we need to make sure that effective communication is as effective in the same situations. And that'll apply to all forms of presentation and exchange of information. So sound, print, graphics, voice, websites, and apps. Next slide, please. So one example of effective communication, let's say a person who is deaf, a mental health provider who uses telehealth to provide remote counseling to individuals may need to ensure that telehealth platform can support effective real-time captioning for a patient who is hard of hearing. So again, just one specific need in this situation, real-time captioning. We may need to make sure that we're able to provide that if we're doing a remote consulting type of situation. So just in general, the ADA states that a provider cannot require patients to bring their own real-time captioner. There's also a limitation on cost. So as far as you can't charge a person for this service. So they don't need to bring their own, and they also do not need to pay a special fee to have that service provided. Next slide, please. So second example, a dietitian who uses a web-based platform to send written dietary recommendations to their patients. They may need to make sure their recommendations are screen reader compatible for a patient who is blind. So that patient who needs that screen reading technology to fully understand and fully gain access to the information in those dietary recommendations. So and it needs to be considered as a means of effective communication in this situation. Next slide, please. Another term in addition to effective communication we need to think about is reasonable modifications. Basically, reasonable modifications are changes to the way we usually do things. Healthcare providers must make reasonable changes to their policies, practices, or procedures. This may include providing additional support to patients when needed before, during, and after a virtual visit to avoid discriminating on the basis of disability. Again, we need to look at what our policies, our existing practices, and our existing procedures are. And in some of those situations, we may need to go above, beyond that, or make a change to the way in which we communicate information. So that would be what a reasonable modification would be. Of course, another key term here, reasonable. There are limitations here based on your administrative ability to do it. There are some cost differences, but in general, reasonable accommodations are things that we're able to provide within the means and the expected provision of the services we provide as a business or a service entity. Next slide, please. So an example, a doctor's office that does not allow anyone but the patient to attend telehealth appointments may have to make a reasonable change to that policy to allow a person with a disability or a family member to the appointment where needed to meaningfully access the healthcare appointment. Again, just modifying that policy simply to make that exchange of information better and the situation easier for everyone involved in many cases. Next slide, please. So barriers to our telehealth access we generally run into. Sometimes we may have a lack of video sharing technology, such as a smartphone, a tablet, or computer. Maybe internet access is spotty. Lack of housing or private space to participate in virtual visits. So maybe the person doesn't have a adequate or an appropriate place to engage in the virtual process. So that could be one of those barriers. Few local providers, depending on where you're at geographically. Language barriers, including oral, written, and sign language. And lack of adaptive equipment for people with disabilities. All these things can end up being barriers to telehealth access. Next slide, please. So we have a number of ways we would suggest promoting equal access to telehealth for people with disabilities. Making materials accessible in different formats and multiple languages. Again, these are some of these things are things we can plan for ahead of time. Certainly we need to modify policies when necessary, but it's always a good idea to think about these things up front and see how many things we can predictably tackle ahead of time and sort of universally design that process to be preparing for what's to come. Use images and words in your online communications for patients with low literacy, multiple means of presenting information graphically as well as in text. Measure patient satisfaction with post-site surveys to improve performance. Using inclusive patient intake forms that ask about access to technologies and patient preferences. This could also include language and pronoun preferences, and it can be a voluntary section of a number of intake forms that people may need to fill out or may not. Just depends on how you set it up within the policies and procedures that you have. Next slide, please. Other suggestions: ask if your patients need assistive devices to participate in virtual visits. Avoid asking about disability, but always ask about additional services that a person may need to participate in general. Think about it in general terms. Do you need an assistive device is much different than asking, are you deaf? So there are a lot of ways to go about this that are very easy to work in to policy and procedure that already exists. Encourage staff to learn how to broaden telehealth access. Okay, so training those staff, consider internal news and progress related to accessibility. So keeping folks on the front lines up to speed on what's happening in the field. Include accessibility options within your telehealth programs. Perhaps this could include screen readers, closed caption optionings, just ways that they can use your platforms to make it more accessible to them. Allow extra time in virtual visit appointments for patients that may need support in getting online, just recognizing some of the setups. And we tend to build those in for all our Zooms, and other types of communication. So think about the needs there. Use technology to design with equity in mind when it comes to speech recognition and health prediction algorithms. Next slide, please. Strongly encourage all patients to get involved in the planning and implementation of health equity. Could include sitting on boards or committees that guide you, providing input on materials or procedures, evaluating what they use, evaluating, giving opportunities for feedback on consumer experiences of customer how the situation went. Just getting that type of feedback often goes a long way. And then conducting sensitivity training can be very valuable as well. Next slide, please. Finally, look for skills and experiences within your team, including that cultural competency, connections with the local community, experience working with underserved patient groups, and fluency in languages other than English. Can't stress enough how important it is to maximize the strengths of our teams. We're more than the sum of our parts when we make sure that we're taking into account what skills people bring to the table and maximizing the output of that, putting people in roles where they can lead, and thinking about what resources we have there on the team already. So evaluate that team, evaluate the skills and experiences your folks may have, and use that to leverage your effort. I'm going to pass it back to Pam and let her take back over.
Actually, Molly, I'm going to punt to you.
Yeah, that's fine. So as we mentioned earlier, we actually have two case examples. These are cases that myself and Pam have offered to share to the team and to the rest of the group as examples of considering telehealth equity with those people living with disabilities. So I'll get started. This is actually a personal experience that I'm able to share with a family member. So the scenario is that we had an older adult with Down syndrome that belongs to a not-for-profit program that serves children and adults with developmental disabilities. They provide day services, in-home services with what are called direct service providers. And then they have employment sites where they have clients that go out into the communities and have jobs and have employment opportunities in the areas that they live. They also have residential sites, and then again, those that offer in-home visits. With this specific case, the older adult lives on their own with a roommate and does not live in the residential community, but does take part in the day services. So each day he goes into the facility, and they have all different types of activities. They have a case manager, and then the direct service providers. Direct service providers in the state of Kansas are not necessarily trained per se, but they have organizational training that they do to help provide support and services to the clients, but not necessarily licensure-based training. So in this instance, the client began speech therapy sessions pre-pandemic. So the therapy sessions were in person with a speech therapist, and then it's an actual education program. So they have graduate students that are working to get their speech therapy licenses when they graduate. So then there was two students that were helping with the therapy sessions. During the pandemic, we had to transition to telehealth therapy sessions. And in the midst of this, discovered there was not necessarily training for the therapists to provide it during via like an iPad or some sort of a visual video. And then on the other side of things, discovered that the DSPs also, they didn't have training, because like many of us during COVID transition had to do some really quick work to provide telehealth. So some of the barriers that were noticed during this time, I actually served, initially the client was in our home. And so I actually served as the aide, if you will, during each session. And we figured out ways that we would communicate. We had to slow down, as Troy talked about. We definitely had to slow down how we conducted the therapy session, but then also had to make adjustments to the iPad in terms of the client being able to visually see the different therapies we had to do with the therapist. So we had to make the screen bigger, and we had to change how the Zoom Health program works so that each time the therapist spoke, it actually focused on the therapist, as opposed to the panel like we may see right now, our visual panel. So we had lack of training for the direct service provider staff. The therapist had not necessarily considered the lack of training for the staff, so we had to make some very quick modifications, because in the middle of this, they were in our home and then they transitioned back to their own home. So we had to consider that as well. As I said, I served as a telehealth navigator to enforce the session activities. And then I essentially worked with the therapist to train the DSP staff for when he returned home to continue the sessions. So there's the benefits that we experienced, and then also, or the barriers. So we also did see benefits. We were able to be consistent with the engagement to ensure continuity of his progress. The clinic does continue to use telehealth. So we have, they've actually sit in on a lot of our HTRC trainings now, and have incorporated it into their own clinical offerings. And then we were able to continue to ensure care in a very rural area. So what came of this too was the future thoughts of, what does it look like to incorporate training in the facility for other clients? So not just the client that I'm presenting on today. And then one of the things too is having we also had to do materials. So there were documents, because there's, and we used the visual. I didn't realize that we were actually doing it right, Troy, but we actually used visual aids because he responded better to what it looked like when people made faces, the nonverbal faces in speak, how he would respond if somebody, if he was speaking with someone and they would make a face like what or So we use those visual aids to help with that. And so what does it look like for the future? Can we incorporate those types of techniques long term? Because there's other clients that are probably having the similar experiences with telehealth. And then reviewing what the technology needs were at the actual center, because he had his iPad, but it wouldn't connect very well at the center. So they would have to use one of those conference room cameras. Well, for speech therapy, that's not very conducive because he couldn't see their face and they couldn't see his face directly. So those are just some things that we experienced with these considerations and what it would mean on the clinical side, and then what it meant on the side that provides his daily care. So I just saw something in the chat. I want to make sure it wasn't a question. So that was the first case. And so now I can pass it on to Pam, and Pam can provide her case example.
All right, so I have been given permission to disclose that this person is my 78-year-old mother, and she has multiple health conditions and disabilities. And her first experience with telehealth was actually during the pandemic. And we began that journey through telehealth because she has an immune she's immune compromised, and we didn't want her to be out and about in the public, and especially in medical offices where she might be exposed to COVID. So we saw multiple doctors via telehealth over several months. Matter of fact, over the last 3 years. And I was the one that was assisting her with connection to these visits and facilitating communication. Because one of the things that we learned early on, even though we're part of a larger conglomerate for all of her doctors, every doctor's office seemed to have a different system that we were using. And so by the time we would learn one system, then we had to learn another system. And so that was one of the downsides, is that we did not have a consistent system for the longest time. And that was one of the things that we were able to bring to light to the conglomerate, was to say, you really need to have a consistent system across your entire medical practices so that we can learn the system and be able to effectively use it. The other thing that occurred that became a benefit in the long run is that because my mother and I are people who try to make suggestions to make things more accessible for all people, is that we encouraged them to allow their medical assistants to become the ones to be the go-to for the technologies. And so it worked well for us in that the medical assistants would start getting on with us about 15 minutes ahead of time, making sure we were connected. And then we didn't have to worry about it. And so we're able to use it. Now, my mother is to be 78 years old. She is semi-tech savvy. She has her own iPhone and she sends her own text. But when it comes to technologies, sometimes I have to be the one to be there to help facilitate some of the communications due to some dementia she now has. And so the doctors became accustomed to me being part of the visits, and thankfully they modified their policies, because typically they would only meet with the patient, but we made sure we signed all the correct HIPAA forms so that I could be part of the visits and it would not be a problem. So yeah, for us, it was a very positive experience, in spite of some of the challenges that we had along the way. And we've seen things improve dramatically over the past 3 years. But we did have, work towards those reasonable modifications, making sure that everyone understood my role as her daughter, and helping to facilitate communication, and really for her to be able to get the care that she needed during that time. So, and I'm happy to answer any questions or have conversation about it.
Pam, I will comment. I think that's a really good point, that you were there to help facilitate, but not necessarily answer the questions or take over for the client, for the patient. I was in this similar position, because it can be very easy to just answer the questions and not continue to support the empowerment of the patient or the client.
Right.
Who's there to do it. You have to slow things down, which we had to do too. And we had to navigate these systems. So, but I think that's a really good point, as the telehealth navigator, if you will, serving as the patient support team on the other end of the appointment, without taking it over and just answering it because maybe the things are moving too quickly during the virtual visit or whatever it is you might be doing.
Exactly, Molly. And I can personally say, just from watching these visits unfold, the medical providers became more comfortable still trying to stay within their relegated 15 to 20 minutes, but they did slow down when she needed things to be slowed down in order to be able to provide the best care possible.
I think this is now an opportunity that we can take for those of you that are on with us today. If you have any questions or any just comments, or if you would like to share any experiences you've had from your clinic that may have worked for you that we didn't talk about today. Okay, I don't see any hands up. I don't see anything in the chat. We can move on.
I'll ask a question, Molly.
Sure.
This may be what you were talking about, Pam, with the MA. Could you describe how the technology itself was introduced? Was there anything that was especially useful, and how the provider or MA kind of did the introduction to telehealth with both you and Molly?
What the MA did for us, first of all, they finally started sending directions to us via our MyChart system, which is our electronic medical record system. They started sending directions ahead of time. So when we first started this, there were no directions whatsoever. It was basically connect to this link and go forth and do good things. So they worked it out. So they sent very specific directions. And then when the medical assistants would then get on with us about 15 minutes early, make sure we were connected, that we could hear, that she could hear us, we could hear her, and that everything was all connected smoothly before the doctor ever stepped into that video appointment. And so basically the MA was really the technology facilitator, for lack of a better word, but he or she just made things a lot more comfortable and made sure that the transition was very smooth. And before we got those directions and had the medical assistant helping us, you know, we ran into some frustrating appointments where we would think we were connected and then we weren't, and then we'd have to try something else. And so that, and they have continued in that, the medical assistants have continued in that role for the virtual visits that they're doing now.
And in our case, it was so new to the clinic, and then also so new to the organization, that I worked with the clinic and I worked together, and we created a small binder. They didn't have any materials that they would send out prior. This would have been 2020, 2021, moved into 2021. So we put together a binder, and then the onus kind of came on to me because we traveled. He's about an hour and a half away. So then we traveled there, and I actually ended up training the team myself. But we didn't have any materials at the time. He's actually going to be entering into therapy again, probably early next year. So I will be curious to see. I have a feeling that there will be some new updated materials that they may then offer to the clients as similar to what Pam was talking about, what she would receive kind of in that preparatory way. And what we see when we work with our telehealth clients across the region, you get that preparatory document now in most cases in terms of how to log in and how to access the links for whatever type of an appointment that it might be. But back then we didn't have that. And but for me and in the role I have now, it definitely opened my eyes in terms of the need for training and what might be available to providers to have these reasonable modifications in place. Were there any other questions or comments before we move into our next presentation? Okay, we'll move into resources. I think these will be really helpful to those that are on.
Yeah, we have provided a wealth of resources to you, Alan, and on this particular slide, U.S. Department of Justice has developed a paper on telehealth, and then also U.S. Department of Health and Human Services has done guidance on non-discrimination in telehealth. And a lot of the information that you saw today came from that particular fact sheet. So we do highly recommend it as a resource for you. Next slide. So the U.S. Department of Health and Human Services has also developed a paper called Health Equity in Telehealth, and that discusses a lot of the reasonable modifications that we talked about today, how to do effective communication, and gives you some of the practical hands-on types of pieces. And then the Southeast ADA Center actually developed a white paper called ADA and Telehealth Challenges Faced by People with Disabilities Accessing Telehealth Services. And that particular document does talk about the challenges people face, but it also then talks about some of the resolutions and practical applications that people used in order to make the telehealth more accessible. Next slide. And then the Pacific ADA Center, one of our sister centers in the ADA National Network, has developed a document called Telehealth and Federal Disability Laws, and it goes into a lot more in-depth information about how the federal disability laws apply to telehealth, and particularly how they apply to people with disabilities. Next slide. So we provide some more information for you about the ADA National Network and the types of services that we can offer you. And next slide. And then we give you some information about the Americans with Disabilities Act, the overview, and then some questions and answers that have been developed of questions that folks might have. Next slide. And then we have also, the ADA National Network also has a fact sheet on accessible healthcare, and then healthcare in the ADA, and then healthcare in the ADA, inclusion of persons with disabilities is one of our webinar series where we highlight disability and healthcare issues. And in August, we'll actually be having some of the telehealth resource centers join us on that particular web series. And then you can join in and learn more, and you might be able to learn more about accessibility for and inclusion for people with disabilities. Next slide. So we've got a couple of resources on effective communication. One is just a general fact sheet that tells you what effective communication is and some things that might work for to provide that effective communication. And then we have one that addresses aging and hearing loss in communication and what are my rights, because as we age, we all tend to lose some of our hearing, and that may be different than folks who are born with hearing loss. Next slide, please. And then last but not least, this is our contact information for the ADA National Network. We do encourage you to call us at 1-800-949-4232 or visit our website at adata.org. The toll-free number will route you by your area code. So for those of you that are in Missouri and Kansas, you'll be routed to Troy Center, the Great Plains ADA Center. And for those of you in Oklahoma, you'll be routed to our other sister center, the Southwest ADA Center, located in Texas. And I believe that wraps us up, except for your last slide here, Molly.
I want to thank you both for presenting today. These are great resources. Having, experiences personally with it, and then also those things that we need to consider. I would highly encourage, if you're going to work on developing outward facing materials or things that will be sent to clients or patients, and you have not used any of the things that are available in Word or Adobe or any of those to make it readable through one of the readers, or at the very least, reach out to the ADA centers. They can help you work through that. They can kind of give you a quick overview on how to assess your document, and it'll give you the little radar that tells you if it's green, orange, or red. I've been using those, but those are important things to consider when you're sending those things out to patients and clients.